Okay, very good morning. My name is Siegfried Walch. I'm heading the department on non-profit social and health management here at the Management Center Innsbruck. And today we run our real-life simulation presentations live streamed on the internet. And I give you a short insight into the real-life simulation and its learning outcomes. The real-life simulation is a course. It's a 10 ECTS course, and our students have the opportunity in this course to explore an area of social and or health policy and economics in depth. That's the idea. This year we have chosen the topic New Primary Healthcare. And this is not an assignment which came out of the blue. It's an assignment which was provided to us by the head of the Austrian Association of Sickness Funds, Director Dr. Josef Probst, and by the head of the Association of Austrian GPs, Dr. Dax. Both of them approached us during the summer and said, well, we are now entering a new phase in the developing of a new primary care in Austria, and therefore it would be useful to have some students who work at this important moment on the topic of new primary care. What is the current state of primary health care in Austria? We have a primary healthcare system which is organized in a way that we have single GP practices, sometimes available 24/7. That's how in former times physicians were expected to work. But nowadays we realize that this 24/7 is not acceptable anymore. From a quality perspective, from a quality of life perspective of health professionals, but also from a patient's safety perspective. And we have learned in international comparisons that Austria needs or has quite some space for improvement if it develops its primary health care further. And 3 years ago, the new healthcare reform defined that and decided that primary healthcare shall be multidisciplinary organized in the future. That we are heading for primary healthcare centers or networks where different health professionals provide primary healthcare in a more comprehensive way as it was done so far, which is quite demanding. Because if you have set up your GP practice, if you have invested a lot into your current practice, it's not easy to move. Because what happens with your investment? If you are not used to work in teams, that's not easy to handle. So how do I find the right partners for a primary healthcare unit? How do I develop a team? How can I manage a team, lead a team? How to organize the process of how to manage the process if a team member doesn't fit anymore? How to say goodbye to a team member in a new primary healthcare setting? These are questions regarding the new way of cooperation, which we are not used to in primary healthcare yet. Other issues are, how do we manage quality in primary healthcare? And how do we measure and observe quality of primary healthcare units? And thirdly, how will this be financed? So there's a lot of open questions, but of course the current debate led to a very concrete outcome, which is a current government bill, which has been negotiated by the federal state of Austria and its lender. And this government bill regulates the finances of the healthcare system for the next 5 years. And this includes a very clear idea to develop 75 primary healthcare centers and or networks within the next 5 years. And this bill also includes the will to spend 200 million euros for initial investments in the next 5 years. So there is some concrete measures from a legal perspective, but at the same time, if you look into the very useful criteria how to set up primary healthcare in Austria in this government bill, you will still find a lot of open questions. Open questions mainly from a health professional's perspective. So if you are the one who is now invited to start a new center in a certain regional context, the government bill says explicitly, make sure that the new center, the new network, fits into this regional context. From a financial perspective, from a quality management perspective, but also from the perspective of how the team is composed. So it all starts again from scratch. If you really want to be one of the early movers, if you want to pilot a primary healthcare unit or a primary healthcare center in Austria. And therefore we said, okay, thank you very much for this assignment, Dr. Probst and Dr. Dax. It's a great opportunity for us to develop some support for young professionals. And therefore, one of the learning goals of this course here is to develop toolkits for health professionals starting a new multidisciplinary primary healthcare center or network in Austria. To make sure that we make use of our network here at the Management Center, linked in our joint programs with Erasmus University Rotterdam, with the University of Oslo and the University of Bologna and other international partners. To make sure that we make use of this network, we invited faculty from the Netherlands, from Norway, from the United Kingdom to support our students in this process and to develop toolkits which are not invented and developed based on literature review only, but which are also used the broad and rich experience from experts of those different countries, which partly are, have developed a very different primary healthcare system, if you compare it with Austria, and which have a similar history. So if you look into the Netherlands, for example, it also came from a single GP practice system and is now more multidisciplinary organized. Further, I have to say thank you very much for those decision makers and those stakeholders of the Austrian healthcare system who advised our students in understanding the Austrian context better, and who advised our students by providing very concrete material for the development of the toolkit. So some of you are following today. Thank you very much for joining us, not only today, but throughout the last weeks. So therefore, we expect to get some very concrete support for everybody who is now entering the new primary healthcare in Austria. And for this, 2 student groups will now present a toolkit which focuses on managing processes and quality, measuring performance of a primary healthcare center. 2 student groups, and we start with those 2 groups, will present toolkits how to build and lead multidisciplinary primary healthcare teams. And the last 2 presentations will be about understanding the risks and negotiating finances for primary healthcare centers. I know that some of our stakeholders said there's nothing to negotiate. That will be decided by the sickness funds. This will be negotiated by the medical association. But we also learned that there is no concrete model in place yet. And if you read the government bill, the current 15a Vereinbarung, which is expected to pass the Austrian Parliament before Christmas and which was on the agenda of the Health Committee of the Austrian Parliament yesterday, if you look into this document, all these new units, centers or networks, need to be more or less tailor-made for the regional and local context. And therefore, I would say there's a lot to negotiate. And there's a lot of space to make sure that this primary healthcare unit fits for the local purpose, but also fits for the people who have to need it, and make sure that their risk is something they can calculate. So here, some final data. We started with the real-life simulation on November 3rd with some pre-readings before. And today we run the final presentations here at MCI Innsbruck. For those of you who are on Twitter, please use the hashtag primary Austria PHC. We will later move to our Twitter wall and use your comments from outside, but also from inside here to run the discussions between the presentations. Here you can see the involved faculty members: Antoinette de Bont from Erasmus Rotterdam, Oddvar Karbø from Norway, Jenny Bremner and Olivia Dix, guest faculty from MCI, who were supporting our teams to set up their project plans in a 2-day workshop, and myself. So here we are, ready to go. I invite group number 1 to give us their presentation. This presentation will be a maximum of, will take about 11 minutes, a maximum of 11 minutes. All the other presentations will remain between 8 and 10 minutes. And after every presentation, we will run a short discussion based on the tweets we will see on our Twitter wall. So I hand over, please. Good luck.
Thank you very much, Mr. Wall, for this nice introduction and overview of the context. We are really happy and pleased to be here today with you. We were all working the last month on concepts how to improve the primary health care in Austria and to form a more integral part, not just of the Austria health system, but also of the social and economic development in the community. We face challenges today because of the ongoing cut of the costs, but also because of political and legal barriers which make a change or improvement difficult. And therefore we really have to focus on more health promotion and prevention, and therefore better public health. And the next step, and the first to do, is calling for more cooperation within the stakeholders. And we, our team, we want to work for multidisciplinary teams in primary healthcare settings. Therefore, in the last month, we did profound research, literature research, but also a lot of interviews and talks with experts of the field. And we developed together with them a suitable toolkit for building and leading those multidisciplinary teams in primary healthcare settings. I have to mention that we focus just on the urban areas, so just in the cities where we implement these centers. Given the status quo from Mr. Walch, I want to start with a short introduction with the definition of primary healthcare and primary healthcare centers. What is this actually? Primary healthcare refers to directly accessible first contact ambulatory care for a big range of unselected health problems, and it is provided by a variety of discipline because it offers curative and palliative, preventive and rehabilitative services, and the services are also on a continuity basis over time and within the providers. Primary health care centers is in a legal context in Austria defined as an agreement to finance and organize healthcare systems, and it's a kind of planning on of multi-professional outpatient provision of care. It is implemented on a federal legislation, and it can be, due to the conditions of the region, either be a network or a primary healthcare center in an urban setting. It depends on rural or urban settings. In the course of our literature research and with the interviews with our experts, we have also identified some advantages and disadvantages of these primary healthcare centers, which we are looking forward to implement. And some of the advantages are, of course, this center will be really strong in promoting and preventing healthcare issues, so the outcome will be a better public health, as well as a lower mortality rate and higher life expectancy. We will also take the burden from the hospitals. We will have less hospital stays because we have a higher coverage in the centers themselves already. And also through a proper implementation of the toolkit, we can achieve a higher quality, more efficiency, and cover more, this is leading also to more equity in the system. Through the gatekeeping exercises, we will reach also more efficacy and cost effectiveness in the system. Some disadvantages might be, like due to US evidence, we found out that the primary healthcare GPs prevent the access to the specialists, or might prevent the access to the specialists, which might lead to a dissatisfaction of the patient in the first run. But for the Austrian context, much more important is that the challenges in the recruitment we're gonna face, because we have to face some shortages in the workforce and really low remuneration, a lack of the remuneration, and also a lack of the physicians themselves. Okay. Now, with doing these interviews with the experts, especially from the primary healthcare center already established in Austria in Enns, we were talking to the manager of the center and came up with a clear structure how a primary healthcare center could look like and how it is organized. So we defined the core team as follows. We're going to have 6 GPs with 6 nurses for each GP one. 4 doctors recipients and 1 practice manager will be introduced to the team. Those will be working on a full-time basis, but we will also have other professions which have a normal contract with the center, but which will be part-time employed. So we combine it with midwives, social workers, speech therapists. Then we're going to have 2 physiotherapists, a psychologist and a psychotherapist. And last but not least, also an occupational therapist. Yeah. But as in Austria, the whole potential of the competences of the healthcare workers are not fulfilled yet, and we feel that the competences are not used to its full potential. We want to make a change management due to the roles and the job descriptions of some of the professions, and I highlighted here the 4 most important changes in the professions. The practice manager will be a new introduction. He takes over the administrational tasks, the communicational management, and the HR management. The GP will hand over tasks to the nurse, like blood testing, urine tests, follow-up of chronic diseases, and consulting tasks. As therapists will be located in the center, they will be much closer and more involved in the whole treatment process, and faster interventions and more effective work is possible. Also, social worker will give more information, and not just to the patient, but also to the family members, and will prepare patients to handle better with the diagnosis and facts. And last but not least, we want to achieve that midwives will be occupied on a 24/7 basis in the centers. Okay, and now Jana is continuing with explaining the exact tools which we want to implement in order to lead and build this team. Thank you.
Yeah, thank you very much, Marie. Like Marie already said, the first part was more about building the team, and now the second part is more about how to lead a multidisciplinary team. Therefore, we organized it in 3 parts. The first part is communication, second part is team leading, and the third part is empowerment and training. So starting with communication tools, it was very strongly emphasized by the expert we interviewed that effective communication is a big issue in primary healthcare center. And effective communication leads to better information flow, more patient safety, more quality, and also more satisfaction of patients and also of employees. Therefore, we have 4 tools provided for you. The first one is team meetings. So effective team meetings ensure that all the team members are on the same page, have the same information. And therefore, we provide you with guidelines how to structure a team meeting and also which roles and responsibilities should be covered in a team meeting. And this is in detail more in the proposal. Second one, which was also emphasized by the physicians we interviewed throughout the process where we came up with these tools, is quality circles. Quality circles are a nice learning experience for physicians where they can have a collegial sharing with other physicians and discuss about patient problems, but also about general problems in a primary healthcare center. The third one is conflict management. So if conflicts arise in a multidisciplinary team, it is necessary to have a kind of protocol how to deal with these conflicts and how to solve them. Therefore, we provide you with guidelines in the proposal how to solve a conflict on one side on a team basis, but also on an individual basis. And the last part, as we all know, when it comes to patient, there's a lot of data, and we have to handle a lot of data. Therefore, an effective and user-friendly electronic health record system is a big issue, and it's key in a primary healthcare center. Therefore, we also have guidelines for you provided what core functionalities a electronic health record system should have, and also how to implement it into the practice. So far to communication. The second one is team leading, as coordination and communication is very strongly influenced by the team climate. We have set up some team leading tools how to positively influence the team climate. The first one is shared goals. So how to implement a shared goals within the team. Therefore, we recommend a kick-off session right before the primary healthcare center opens. Have a kick-off session where the whole team comes up with common basic principles for the process, for the project, which will enlarge respect and also the loyalty within the team. The second one is throughout the whole process of the project, team building is a very big issue. As we all know that time is a very constrained good in primary healthcare, we recommend to combine these team building measures with events like a Christmas party, where every team member has certain tasks, has to fulfill certain tasks, and therefore relationships are strengthened. It lowers the strict hierarchy that may be, and also they all want to have a nice Christmas party, they work towards one common goal. Empowerment and training is the last tool we want to provide you with. We recommend to find a team leader who is, for example, responsible for solving conflicts in the team. Therefore, we also recommend to hire an external coach who supports the team leader in the first phase and also guides through the first sensible phase when the team comes together. And also the external coach can intervene when conflicts arise within the team. To sum up our tools, we have the key principles highlighted here. We wanted to aim and realize within these guidelines. So clear roles were provided, effective communication within the team, shared goals and mutual trust through the team building process, and a short outlook to the quality management team, measurable process and outcomes will be provided to you. With this, I want to end our presentation. We thank very much the experts for their time and information, and thanks to you for your attention.
Thanks very much for this first input on how to build a multidisciplinary team. I know that your seminar report will be even more detailed, and people who are interested to read further can contact us and can get access to your report. First of all, if I understand it correctly, this communication efforts which you have described here might require extra time and extra costs. Who would like to explain us how this can be organized in the future and how this can be covered? Maybe health professionals, physicians might say, there is no time. I don't see the resources to do, to invest so much time in communication. How would you react on that?
For example, when it comes to team meetings, they should be implemented in the core hours of the team, so they are not additional, but within the working time, and it has to be very good planned beforehand that all the team members can be available and that they sometimes change, that somebody is at the front desk and provides the patients and the others can switch, that somebody is always in the team meeting. That could be one example how to handle this.
Also, as we have this advantage to work in an urban setting, we are in one institution where we can find some incentives for the workers to volunteer and realize the benefits they can have in investing in a good cooperation and a good work atmosphere in the working place. So I think the institute itself will promote and make them investing time for this.
Thank you. Do you think that the sickness funds, the social security funds, will have to provide some extra budget for communication, for information exchange, for discussions about the patient situations, for, well, providing patient safety and quality in primary care by working in teams?
As we are not the finance team, I cannot answer it from a financial point of view, but I can imagine as nowadays we are so improving in IT, information technology is not really expensive. If it's organized and managed in a good way and we are having one IT, like one system for all the workers and all the stakeholders, it can be solved in a really cost-efficient way.
Okay, so you're very confident in here. Irina Rombach on Twitter says, how can we incentivize health professionals to communicate knowledge and to promote take-up in practice? Yeah. The question was how to incentivize.
Okay. So what we thought that, of course, for physicians, the patient should always be in the focus. And therefore, we think if people or the physicians communicate more, it has like a better outcome for the patient because everybody can bring in his or her idea, and that's what the focus should be. So, I think.
Yeah, and we said that they could give up their tasks to nurses or the practice manager, and so they would just have more time to actually focus on the patient's needs. So it's really a focus on the patients, and that should be the most goal.
Thank you. I just want to add that we also focus a lot on effectiveness, that it's effective, and if they have a shared collegial with other physicians who might have the same problems, it's saving time in the long run because they don't have to deal with the same problems all over again when they share information.
Thank you. I saw another tweet up there by Antoinette de Bond. Antoinette asks, do you think that primary healthcare centers will be mainly positioned in cities? Or is this something which can also be useful for rural areas? What is your guess here?
So we have two groups. Our group is only like focused on the cities, and the next group is focused on the rural areas. And I think there it's more about networks. There won't be like one huge center where all the professionals have their offices in, but it's more about networking there. So I think both parts are really important.
Yeah, I agree, thank you. I just think that by our research and our interviews we made, we got to know that stakeholders and GPs really prefer to have face-to-face meetings. So I think even for the rural areas, it would make sense to have at some point a common space, a common office to meet once in a while.
So what we have seen in real life is that there's one center in Mariahilf in Vienna, almost 2 million people. They established the first primary healthcare center, multidisciplinary, organized in Austria. A second one in Enns, and you interviewed the general manager. This little city has a population of about 12,000. And we said, okay, in the first presentation, let's discuss the center, which might be mainly linked to cities, because rural areas in Austria, in the mountain area, usually create a lot of travel time for patients. So our assumption for this course was that the networks might be better for rural areas or easier to implement for rural areas because of the long distances which we want to reduce for patients, which we want to make, we don't want to make it too difficult to access primary healthcare in rural areas. And therefore we said, okay, let's link the center to the urban areas and let's link the idea of the network to the rural areas. But of course there might also be the one or other center or a joint facility in a rural setting, and there might be the one or other GP who prefers the network because he doesn't want to give up his investment, even in an urban area. So we made it a little bit easy and said, okay, let's link the center to the urban area and let's focus on networks in rural areas. Thank you very much for this first presentation. I think we are now getting warmer and warmer, moving quickly to the next presentation, which is also on building and leading multidisciplinary primary healthcare teams. And this group now focuses on a networking toolkit. Before I hand over to you, applause for the first group. Thank you to all of you. Okay, Lisa Maria, the floor is yours.
Our project team wants to welcome to the presentation. As Dr. Walker already said, we focused also on the building and leading of multidisciplinary teams in primary healthcare, and our focus will be on the networks in rural areas. First, the structure. We want to guide you through the next 10 minutes. We read it every day in the newspapers. Challenges are coming up in healthcare system, in social system, and so on. But when it comes to rural and urban areas, there's a huge difference because the gap between urban and rural areas is increasing more and more. Therefore, we focused, as I already said, on the rural area. The challenges there are, we have wide distances. There's the problem that there's a migration of the younger population to the urban areas. Therefore, the professionals, especially also the health professionals, are missing in the rural areas. Furthermore, the population is mostly older people, elderly. The disease patterns are mostly comorbidity or chronic diseases, so therefore the disease patterns are similar from day to day. Also, it leads to a low attractivity for physicians who actually don't have change in their workload or in their job. In addition, there's no opportunity in the rural area for further education. So therefore, there's not really an incentive for the GPs to go to rural areas. This was the reason why we developed the following toolkit with the purpose to create a guide for improving the network amongst the multidisciplinary teams in the rural areas in Austria in primary healthcare. First, I want to speak about the team design. We decided after some researches that it makes sense to begin with a small team. Why a small team? For the founder, it's minimizing the risk as well as reducing the complexity. Therefore, our team will be designed as followed. We have the general practitioner who will have a leading position, then the nurses. We researched that there was a change in the law, so therefore since September 2016, the nurse can have more responsibilities and more tasks and therefore relieve the physician. Then we have a social worker because in the rural area the social context is important, especially when it comes also to the networking, because relatives play a huge role when it comes to mobility. And then we have the healthcare manager in order to ensure a good complexity. That's the core team we want to focus on. But when it comes to different projects, or perhaps there are different problems in a special region, it's always the possibility to create partnerships. The partnership we were thinking about was, for example, specialized physicians, psychologists, etc. But as I always said, it depends on the social context, on the regional context, and on the demand of the population. Now, Tiran will go on with our tools.
Okay, thank you, Lisa. The purpose we held a multidisciplinary team meeting is to sharing the information and discuss the case. And there's one minimum requirement to hold this meeting is that at least one people from each health professional can attend this meeting. And there are two ways we hold the meeting, online and face-to-face. if we use if we hold online meetings, we can use the VPN's encryptions in order to protect the patient premises. And the frequencies of the meeting is set once every 2 weeks online meeting and once every 3 months, so face-to-face in the afternoon, because that every health professionals can finish their normal tasks. Okay, our core team involved two kinds of nurses. One is geriatrics nurse, and the other is that coordination nurse, and also house manager. Because house manager can budgeting for the meeting and organize the meetings. Before the meetings, GP and the nurse find some cases going to be discussed in the meeting. And the members can receive email about the cases, then they can prepare for it. During the meetings, the members need to report the cases, and then all the members discuss it. In the end of the meetings, the coordination nurses need to summarize the care planning and then follow up the cases. Yeah, sometimes that during the meeting, someone knows there's a problem, but maybe the others can't get in the same movies. So we're going to introduce a communication tool called SBAR that to make the meetings more efficiencies. After the meetings, we're gonna share the information through the eHealth platform and Elegance. Connect this to with other partners, for example, the therapists and dietitians. They can give some feedbacks about the cases. And the benefit of this is there's no information asymmetries, and they can faster react to the emergency case. Okay, Lisa going to explain more tools.
Now we're coming to the team building activities. As we all know, a team needs to be strong. There needs to be trust. It needs to be respect. There are several I would say there are several categories that need to be fixed. So therefore, we were thinking about exercises, team building exercises, who actually can be implemented when there are conflict situations, or if there's, for example, an emergency and a conflict exists. We actually want to kind of promote exercising. So therefore, we created a catalog that is based on a Harvard tool development kit, and we want to transform it to the primary health network. Furthermore, we want to promote the exchange between the professions. So therefore, under the slogan TRUE, so trust, respect, and useful exchange, we will have some dinners all 3 months after the meeting, and therefore an exchange of information, private as well as for sure about the job, can be held. In addition, we need further trainings for the physician. We recognize that there's a low incentive for the physicians to go to rural areas because there are no training opportunities. Therefore, we offer an online leadership class or course for GPs where they learn about the personal leadership and how to implement a team strategy in order to be effective and reduce conflicts. The right communication is an important tool, and also this tool is based on the Oxford Medical Association. All in all, we can say that if we create a functioning, leading multidisciplinary team, and the team works with each other and they pull together, then we can have a high quality, we can have effectivity, we can ensure the delivery of healthcare in rural areas, and for sure the health system can be more efficient. So, thank you for your attention.
Wonderful. Thank you very much for this second presentation on how to build multidisciplinary primary healthcare teams. Thanks to the whole group. We again have quite a few remarks and questions on our board here. I would like to start with one, as you have presented quite a few methods and models how to establish good communication in such a team. Antoinette de Bont asks, if you need to prioritize, what would be the first communication tool you would focus upon? Yeah, if you would have to prioritize, where would you start?
We actually thought or think that it's the communication tool, it's SPA, because it breaks it down. The complexity of the whole process and about the case is break down through the SPA model, and therefore it ensures a good communication between the professions as well as a good communication with the patient. So it's understandable for every profession and for the patients.
Okay. Thank you very much. Another question. Johanna asks, building a team, what is the rationale behind choosing the GP as the leader of the team? Is there a need to have a GP as the leader of the team, or can GPs also be members of the team?
Thank you for the question. Our focus is for the team meeting, GP is a leader because current setting as an autonomy. So it's quite difficult to be a leader as a healthcare manager. But our point is our core team leader is a healthcare manager, like as a graduate of us, because like we can see both like the whole picture of healthcare system, and also we can focus on health and social needs. So healthcare manager to be a leader of multidisciplinary team, but like we focus on the meeting. So meeting is a GP is a leader.
Okay. So in a good team, leadership can change. Yes, please. Lisa?
Especially if we don't, we should not forget that the nurse prepares the meeting. So therefore, the nurse has kind of an indirect leading position because she creates the agenda. So therefore, I mean, we know that GPs are more or have stronger personalities, so therefore it's kind of giving responsibilities to them, but also holding the motivation of the nurses up through indirect leadership.
Okay, great. I think we can continue discussing this much longer, but I know that we have to switch to the next presentation. Thank you very much to you. Just one very last question. Antoinette de Bont says, I like the idea of the core team, eager to know the argumentation that explained the composition of the team. One or two remarks on that. Maybe I can try. Well, the current debate between the government and the regional governments somehow has a kind of a minimum consensus which says in a multidisciplinary primary healthcare team, we want to see the GPs working with the nurses. That's the minimum consensus. And we hope that they will add, according to regional needs, other team members. There's another question, how will we measure what is the most effective team for which community or which region by Irina Rombach. So if it comes to the composition of the teams, we have to link that to the whole debate about quality management and indicators, how to measure needs and provided services for primary care centers, and that leads us to the next presentations. Thank you very much to you for your input, and yeah, we are very much looking forward to your further research in this. Thank you. Alessandra, I hand over to you and your team. It's now about the quality toolkit for primary care centers, and we are very curious to see what kind of findings you will present and how the debate will look like afterwards.
Thank you so much, and thank you everyone for joining us here today. My name is Alessandra Gessel. This is my colleague, Michael Zeiner, and we'll be talking to you about our quality toolkit for primary care centers in the urban areas. Now, our mission was basically to improve primary care in Austria, and our task within this was to develop a toolkit for process and quality management and measurement of performance in the urban setting in Austria here. So I'm just going to give you a brief overview of what we're going to talk about today. First, I'm going to give you an overview of our entire toolkit. Then we're going to exemplify our toolkit based on 5 tools that we selected as particularly important. And then I'm going to touch upon the benefits of using our toolkit. Now, let's dive right into the overview of our toolkit. Now, it's based on 4 pillars, which are quality assurance, data collection, data analysis, and the results and change management. Now, quality assurance, we've got 5 tools here. A few of these will be exemplified. So this is just basically to be able to get you started in how to improve your primary care center right from the beginning, how to ensure quality right from the beginning. Now, our second pillar is data collection, which is divided into 2 tools. First, we've got the quality indicators, which are defined and measurable items to assess, review, and set your standards. Now, we reviewed these 2 publications that you can see above, and we selected 28 indicators grouped into 7 different groups. Now, of course, you've got to somehow measure these indicators, so we came up with also 3 surveys, 3 main surveys that are going to be one of the main ways with which you can measure your quality indicators, 2 patient surveys, and 1 team assessment. The third pillar in our toolkit is data analysis. This is basically split into 3 main tools, the first of which is data, qualitative and quantitative data. How can you use these types of data in your primary care setting? And then we've also provided you with Excel spreadsheets, two of these, that we've developed so that all you have to do is input the raw data that you've collected from the surveys, and these will automatically generate the kinds of data seen on this screen before you. There's tables and there's kind of data that you can begin to use and analyze to see where your weaknesses may lie. And the third goal, or third tool, is how to set targets and goals, because we've heard that clearly defined targets in a primary care setting are an integral part. Now let's just wrap up this section with the 4th pillar. It's the results and change management. So you've collected your data, you've analyzed your data, now you have to actually do something with your data. So the first thing you might want to do is report on it. So we've provided a template of how to report and how to tailor your reports to your different stakeholders. In addition, identified those few key areas where you might want to improve your primary care center. We've included 3 tools: the run chart, the Ishikawa diagram, and the plan, do, check, act model, with which you can begin to implement changes in your primary care center. I'd like to thank you for now and hand over to Mikael.
Thank you. We have now gone through the 4 pillars of our toolkit. We will now give you a visualized experience of how the patient pathway is through the primary care center. The first the patient will encounter is the patient sorting system. This is a system we have based upon the advanced access and the Manchester triage, which is already incorporated in medical system. The system works as following. First, the patient will encounter a nurse at the primary care center. This nurse will then note down what the symptoms are, personal information, etc., etc. After this, the nurse will guide the patient to the correct physician. May this be a physiotherapist, a psychotherapist, or a general practitioner. Doing this will ease the burden on the general practitioner, who will do less administrative work and has more time over to do patient treatment. The next thing the patient will meet is the health behavior assessment. Coming into the waiting room, they need to take a questionnaire, will validate which risky behaviors they have regarding their health. It's based on 4 dimensions: the alcohol, nutrition, physical activity, and cigarette smoking. The questionnaire is a simple designed questionnaire who simply asks for basic information about the regarding 4 dimensions. This will give a good overview for, as mentioned, the risky behavior of each patient, and this can be found in our proposal. Thirdly, chronic care. Inspired by Wagner, we have created a chronic disease management circle, which is basically 4 circles, while we will focus now on the self-help groups, which is the largest part of it. The 3 other points can be found in our paper. Self-help groups are groups where patients with chronic diseases can go to create networks to support them and how to cope with a chronic disease. In Austria, there are self-help friendly hospitals, while in Germany they also have self-help friendly institutions. We provide you with a quality criteria to incorporate 8 qualities that you can use to get a certificate to be a self-help friendly primary care center. Being this will create a better communication and collaboration between self-help groups, self-help associations, and the primary care center. Next, it's the referral process. Today, the referral system in Austria is lackluster. There are no real system making communication and coordination between primary care and specialists functioning well. If we can create the mindset to move from a referral letter system over to a process, we can enhance the qualities of continuity of care, communication, coordination of care, and enhanced quality of care. We provide you with 2 tools. First, we provide you with the referral form and a back referral form. These are filled out by the physicians, hence the referral form by the general practitioner, while the specialist fills out the back referral form. The referral form is sent electronically or with the patient to the specialist. But to ensure that the communication also comes back to the general practitioner, who is the main treater of the patient, we also give you a back referral form, giving you this opportunity to create the process. The second tool is the guidelines to how you use these, which can be found in our proposal.
Thank you. Now, the patient has moved through our primary care center and he's about to leave, or he or she is about to leave. But before they do, they are asked to fill out a patient experience survey. And this is incredibly important because patient satisfaction, patient experiences are a criterion for high quality health, or high quality, in primary care centers. So we developed a survey that we've provided in our toolkit based on 2 other surveys, best practice examples, one from the United Kingdom and one from Canada. And the benefits of using a patient experience survey are that, first of all, the patient feels incorporated, they feel heard, and they feel like they have a stake in the primary care center. Second of all, you can have a systematic way to get insight into your processes and which are working and which are not working for your patients. Third, you can improve, redesign, and monitor your processes over a long time. And once you begin to redesign and change your processes, you can begin to adapt them to your patients' needs. And as you do this, you can improve satisfaction and health outcomes in your primary care center. So let's zoom back out. And now you've seen the pathway of a patient through our primary care center. Now, if I might just remind you of our 4 pillars, these cover basically the first 2 pillars, quality assurance and data collection. Now, once a patient has gone through this system multiple times, you can begin to aggregate data, you can begin to analyze it, and also working together with, for example, patients' associations, you can begin to implement changes and make improvements. And this is where the 4th pillar, results and change management, comes into play. Now, I'd just like to come back and highlight the benefits of using the toolkit. So you can, first of all, provide continuous and coordinated care to your patients. You can improve processes and performances in the long run, and you can not only increase patient, but you can also increase team satisfaction. So in the end, our goal was to offer you a simple guide on how to measure performances, on how to manage your processes, and how to increase your quality at the urban primary care centers in the Austrian setting. So with this, I would like to end. Thank you very much for your attention. I'd like to invite you to ask a lot of questions on the Twitter wall and also to have a look at our toolkit. We're incredibly proud of it, and we would love to share it with you. Thank you so much.
Thank you very much, Alessandra and Michael, for your presentation. If we go through that here, through our Twitter wall, just one final remark to the team discussion, to the earlier team discussion. Antoinette, Rotterdam, says, we tested the hypothesis, need the GP be the chair? The answer is no, not for organization innovation. So just as a final remark. Then we continue. Yolanda Bauer says, how do you consider the elderly population in rural areas in your concept? Or how do you consider the composition of the patients taken care of in a certain setting in your concept?
Well, at the moment, to be able to build up a primary care center in Austria, I think you need a regional needs assessment. So before this can even begin to be built up, there has to be some kind of analysis of what the region needs. So I think that would be addressed before you actually build up your team and build up the primary behaviors assessment that we were talking about. This is also especially because we have the 4 dimensions of health risk behavior assessment. So we can begin to, using this, we can see what are the regional needs, what kind of risk behaviors are the people partaking in, and how can we tailor our health promotion and prevention programs to fit those needs. I hope I answered your question.
Antoinette starts with a question, what is the current status of quality management in primary healthcare in Austria? So what is already there, and where do we start from? Where can we build on? Do you have any ideas on that?
Thank you for that question as well. Actually, that's kind of a difficult question to answer because at the moment we have all of these single GPs practices all over Austria, and at the moment they're being monitored. The quality monitoring process is being done by a daughter organization of the Austrian Doctors Association. So there might be a bit of an issue with that. The quality criteria are being completely changed at the moment, also in combination with the new system that we're trying to put in place. And I'd like also to refer to a wonderful document by Dr. Sylvia Turk. She actually published minimum requirements, minimum quality requirements for primary care centers, and that's a wonderful document also to look at. We have linked it also in our paper.
You framed it very carefully. There might be a conflict of interest if the medical association itself measures and controls and manages the quality. So there for sure is systems in place, but we have to discuss how this can be independently audited and how this can be developed into a more peer audit system, which is not in place yet. Okay. Let's continue with the questions up here. I think Johanna says, is it more about the quality of service or the quality of care? So if you, for example, use a patient experience survey, is this something which highlights service and forgets about care? Or is it just an additional element in your whole quality management tool? Again, you, Sandra?
I'm sorry. I seem to be hogging the microphone today. I would say it's both. So as I would like to highlight again that we have many, many more tools in our quality toolkit than the ones that we highlighted today. One of the ones that we highlighted today was the patient experience form, but we have others that, for example, the clinical risk management certificate, which will go into the care. So it's not only about the patient experience, but we decided in the tools that we highlight to actually focus only on the patient experience.
There's two questions which I would like to connect. Antoinette says, how can quality management drive a paradigm shift from referral to continuity of care? And Patrick further up says, what about an electronic patient dossier where as well the specialist as the GP can? How shall we organize the future connection between the primary care units and the specialized care experts?
So basically with our paradigm shift from a single referral form to a referral process, we actually provide those 2 tools mentioned to get started, but we are sure that this is only the first step towards really a referral process, and with that also to continuity of care. So further on, there for sure has to be more improvement, but we are sure that our referral process forms are the best start.
Okay. Thank you very much. I know we are a little bit under time pressure, that's why I move on. Thank you very much for your contribution. Here is your applause. And here is the second presentation on managing processes and quality, measuring performance of a healthcare center. Here we are.
Thank you. Thank you, Professor Siegfried. Hello, everybody, and welcome to the presentation today. I, along with my colleagues here, want to welcome you gladly here, and we are going to talk today about a toolkit on managing processes and quality, along with measuring performance, especially with a specific focus on rural areas. So this is the content overview of the presentation, a small introduction, why we chose the specific rural area and aim, what is the aim of the project, and what are the indicators, how the toolkit looks like, and what the conclusions and limitations of the project might be. So Austria, as we already went through a couple of times, is going through a huge reform. So there is a huge felt and expressed need for primary health care centers to move from solo GP practices into multidisciplinary teams. And a toolkit which constantly oversees the quality and monitoring and change management so that the performance stays very high is essential. So we came up with a variety of indicators that span over a wide spectrum of subjects which help and analyze improve quality, which I'll be getting to in just a minute. So the main aim is to focus on these indicators and help analyze and monitor the quality of processes within the networking of the physicians. And then we also have an educational purpose in the toolkit, which helps stakeholders and physicians to easily understand and break down the complicated process and how to put into daily practice. Region is this toolkit is focused for predominantly rural areas, which are quite, as you already know, rural areas. They have very sparsely located healthcare centers where there might be access issues, equality issues, and higher prevalence of non-communicable diseases along with aging population. So this is what the indicators look like. It spans over 6 fields: patient experience, access and equity, public health, continuity of care, how communication and cooperation takes place within the network, and financing of it. All these indicators are directed and focused to achieve these results which are desirable, which is the treatment and care of the patient. It should be patient-centric, patient-focused, and the tasks between the team is very well distributed, which leads to better work-life balance, and also to make the multidisciplinary team as cohesive as possible. Okay, now I hand it over to my colleague Tina.
Thank you, Kartik. I would like to continue with the toolkit that we've developed through our research. So first, we just split up the tools kind of in 3 phases. The beginning phase will be kind of about analyzing the context and the culture and planning and gathering the data. Then the middle tools will be more about managing the processes and the quality. And finally, at the end there, the couple of tools will be about measuring performance. So unfortunately, due to the time constraint, I won't be able to go into detail about all of these, but we do welcome you to look into the report for more detailed insight into the toolkit. First, we have the force field analysis, which is a great tool to understand the context and the culture, and also to assess the stakeholders and spot any kind of restraining or driving forces that the project may have. So it's basically a chart where you fill out as many stakeholders as you can define, and driving forces and restraining forces, and then you rate them on a scale. And in the end, you can find which supporting and which restraining influences you can have. And to understand the analysis of this in the end, you can decide whether to go ahead with the project or not, or you can identify areas of improvement. We also have data creation, which is used, we can use it for gathering data through surveys or diagnostic analysis, appreciative interviews, and so on. And this would be used for hard evidence and to support any kind of projects that you want to initiate. We also have the education tool, as Kartik briefly mentioned. So we want to get all the workforce and every healthcare worker and everyone involved in the network to educate them on the indicators that we have and to get everyone on the same page, basically. Then we have some effective meetings, and won't talk too much about this because some of the other teams already talked about it. We use the 4 Ps method, so plan, prepare, participate, and pursue, to get that meeting really to have an effective result in the end. We also have patient involvement. So we really want the patients to be involved in the healthcare process, and we really want them to feel like they're a part of the decisions that are being made. Again, we'll have examples for patient partnerships and also experience-based co-design. More details in the report, of course. So performance reports as well. So national audit, benchmarking data, and we also have clinical audits as well. They're also used to identify areas that we can improve on. The clinical audits, we also recommend that we use them with a lot of other tools, like, for example, the run charts, which I will get to in a bit. The clinical audits are also kind of used to plan. So in the beginning phases with the other tools in the top there, to manage the process, and in the end to measure the performance. So they're a really wide tool that can be used. We also include a lot of detail on how to write one of these clinical audits and all the sections that need to be included, as well as all the questions that need to be answered. So a run chart, we added in there to measure the performance. So basically it's a graph of plotted data. So if you have number of events that you want to decrease, let's say that there's too many prescriptions, and you just plot it to track the progress, and then you decide you want to decrease this. So there is a point of change. So you implement a project and you want to see how this has influenced the results. So you can easily track what has happened and whether the project has had any effect. Network tool. So since we're working in a rural area, networks are a little bit more difficult to handle than in a center, and communication may not flow as smoothly and so on. Networks can also be big or small, it varies, and so we decided that we need a tool to kind of self-reflect and self-assess how the network is doing and how everything is, how the communication is going. So we have things like trust and relationships, shared goals, vision, and so on. And basically, it's in a chart like this, which it's a little difficult to read on here, but this is just a little snippet basically from the whole table that we have in our report. And you basically rate each of these features in a capacity and a priority section from low, medium, and high. And then in the end, you can also enter comments of where to improve and what is lacking in the network, and you can really see how the network is communicating. So finally, I'd like to touch upon some limitations which we have identified, and not only with this toolkit, but a lot of these toolkits have some limitation to some extent, and that can't always be avoided. So for example, long-term usage. All these methods kind of require a dedication and a long-term use. We can't see a change in quality overnight. That's just not how it works. So we need to spend the time and the money, and sometimes it could seem like a financial strain and time-consuming, but in the end, it is worth it, and it will show results. Therefore, so it could be hard to motivate some of the workers. It could be a little bit difficult to motivate some of the GPs to get on board with this, since they have a lot on their plate already. Then Austria as well, cultural barriers are on there because there are some cultural conditions that may prohibit or may restrain some people and their willingness to change. But all of these are just some of the things that may stand in the way, but we believe that with this toolkit, We have really designed it so that it's a general kind of guideline for primary health care networks to guide them into kind of improving their quality. So thank you very much for your attention. We're welcoming you to ask us any questions, and we would also like to thank the experts that we've collaborated with throughout the past couple of weeks. And yeah, thank you for listening.
Thank you very much, Robertina and Kardik, for your presentation. There's a few questions already online. Otvar, Karbe, and Antoinette de Bont both ask, can quality management be the same for urban and rural areas, or how to explain to patients if there are differences? So how much did you discuss your presentation with the colleagues from the first presentation, and how much did you care about possible differences or similarities?
Thank you for the question. Yes, we did collaborate a lot with our partners on this, the other team, and the tool every toolkit can be manipulated so that it is adjusted to an urban or a rural area, but the only difference being that in the network there is no actual primary care center where all the disciplines are under one roof. So the communication, and there might be some differences and challenges in communication and cooperation, but we assume that ELGA is in place, and it's already that every network that the GP has is already transmitting information electronically. And what quality management, when it comes to that, depending on because of the varying need, yes, there is a difference, I would say. Yeah.
Yes, please. Yeah. We collaborated a lot with the other group, but the thing which maybe makes us a bit different, since we have a networking position and not a center, is that within each tool we have different options. So it will be more like situations to choose between in a center, like in a networking and in a center, and that's why we also provide more elements than the other group, I would say.
Okay, good. Thank you very much. So a menu to choose, kind of. Okay, but there's another question. Is there a difference between quality management and providing high quality care? And is this difference relevant? How would you address this question? So quality of care versus Robertina.
Quality management is a more general term, I suppose, and quality of care is just a part of managing the quality. So there are many aspects that go into quality management. So like we've seen, it's about the team itself, the collaboration between the team and the GPs and everything else, and eventually it all leads together into providing a good clinical care for the patients as well.
Okay, so a patient who is very happy with his or her GP might not be interested about any quality management tool behind the scene. So as long as the care is good or perceived as very well. So I think that's one of the key questions where we won't have big differences between the expectations now and in the future. But as you said, we expect that proper quality management and proper management of processes and the cooperation between different professions will lead to better quality in healthcare as well. Okay, good. Thank you very much. One final question, and I think Otvar Karbe mentioned it very early, and Petra Stöckel came up with it very recently on the Twitter wall. Both asked about the links between the interface between primary care and the hospital. How would you see the cooperation with hospitals and from a patient's perspective, for example, in oncology?
We think it's absolutely essential. And of course, with a better primary healthcare, it will also be a better coordination of care, which eventually, hopefully, will end up with a domino effect of a better healthcare in total. So we absolutely see it as it's related to each other in absolute many ways, I would say so.
Okay. So especially if you do not only refer your patients to the hospitals, but if there is a close communication with the hospital and you take back the patients you take care of, there might be a more seamless process of care as we are experiencing it today. Yeah, Kardik?
If I may add, during my personal experience, I found out that there is an electronic system where sensitive information needs consent from the patient, which the assistant arts who's in the station gets a written consent from the patient, and then he contacts the physician who overlooks or oversees the oncology treatment and gets all the required information for the patient. Yeah.
Okay. Thank you very much for the group. Kardik, Robertina for the presentations, to all of you for working on this piece. Again, a few quite interesting questions which might lead to the one or other master thesis. Yeah, you never know. Good luck. Here we move now on to the final part of this morning live streamed session on the financial aspects of the new primary healthcare. And we called it negotiation tool, or negotiating finances from a young physician's perspective. Okay, let's start.
Thank you very much, Professor Seegfeld. I'm Rashid Khaldoun. I will present on behalf of our team, Fakiri, Moreira, Ruko, and Flor Chut, our toolkits, which is based on financial negotiating for young GPs. I will say that we are pleased to take part of this debate focused on how the new primary care can run. So the outline of our presentation, it's introduction, a rationale about goals of our toolkits, selection regarding fee for services and performance component, the negotiating part, and information about the stakeholders and the conclusion. So we were really enjoying this real life simulation, and our team were multidisciplinary and running as a consulting company to provide needs for the GPs who need to negotiate. We were looking at doing an assessment to know before to start and to address this topic. And from the financial point of view, it was important to see that according to literature review, according to exchange with experts and stakeholders that we met and we ask questions and we have a debate, that mainly primary care, it's cost effective through reducing unnecessary healthcare services, through sharing costs, and through a containment of integrated care. On the other hand, it's important to mention that there are some challenges. Mainly, financial models are still unclear. There is a kind of uncertainty. The challenge to combine quality and cost, because providing high quality sometimes will cost some additional money. And sustainability, we know now that the start, it's based on flat rate. The government and the sickness fund will collaborate to give financing, but question about long term. Reason why, to empower, to make primary care more effective, there is a need to strengthen the capacity building. Remuneration models must be provided to help. Enhancing condition as equipment, space, and also investing in training, which is very important. The rationale, basically, and goal of our toolkit is providing a concrete evaluation and analysis of different payment modes, also different tools and theories how to negotiate. So I will invite you to have a look in our paper, which is providing a deep evaluation analysis regarding different payment models, definition, risk, advantage, disadvantage, and best practice. Here, we will just point out some mainly 3 important points. First, better to not make a big change, for instance, to keep the same model in order to reduce barrier, to make it more acceptable by the teams. And in the literature and the best practice, fee for services and payment for a quality or performance according to indicators and according to certain clear framework was mentioned as the best way to make this field more attractive and more producive. Some examples is like treating NCDs, diabetes. You give incentives for these teams who are providing this kind of care. Also, undertaking meetings for case management or for management are some solutions who can provide better quality. So here we are in the main important part of our toolkit, which was based to provide a simple approach how a physician can, according to what he knows now in regarding finance and payment context, to address negotiating. So it's not just about knowing tables and payment and scale and full equivalent time, but it's a context. You need to sit with your team, to listen to them, to know their problem, to know how they want to provide and give a certain quality of services. And on the other hand, being prepared, it's good, because it will be your tool to address the other side. But sometimes also it's a process based on learning from doing. It can work from the beginning. If not, you need to keep and to adapt it to the context. So how to prepare? Mainly, as I said, it's not just about finance. It's about condition. It's about context. It's about the need of the population. It's about the capacity, how we can provide this quality of care, but also take into consideration the stakeholders, the payers, or others who can be involved. You need to take them into consideration to reach one line, the same line of communication, the same line of approach, and the same line of objective. Additionally, I will say it's an ongoing process. So basically 3 big ideas. Sit with your team, listen to them, together in a team spirit, draft a goal or goals for your activities. Detect the value, what are the stronger points, so you can defend it. And then also don't neglect, if the other side is powerful, how you can address the negotiating. Important to keep in mind that you need to sit at the right table to speak the right language and with the right person, of course. Basically 4 main steps. So objective need to be defined before to meet the stakeholders that you already defined and know what are their expectations, what they like, what they don't like, that you can have an easy going exchange. In the end, good to build up a good consideration of relationship. Networking, it's very good and especially face-to-face is the best way to communicate. So before to end, how to convince stakeholders? There are many advantages. So I would say for physician, is sharing resources, better work-life balance, like for some female doctors, they prefer now with the new approach to have time for family and to have time also for working, so it will be a good idea. Team, it's a good area of working, cooperation, communication, patient, reducing unnecessary time, reducing indirect costs like transportation. For the sickness fund, this is to have a common system, not fragmented, one line for transparency and accountability. I will conclude, so this a new primary care reform. It's attracting a lot of interest. That's why the debate is open between the whole stakeholders, GPs, sickness fund, the Chamber of Doctors, and other stakeholders. For sure, it's an ongoing process. There is a need to understand the context, to understand our need, to understand the need of others, and to draft a simple strategy with a good flow of communication to reach better primary care in the future. Thank you very much, and we will come here for questions.
Thank you, Rashid, and the whole team working on the topic of, well, how to negotiate finances for new primary healthcare centers. I would like to add a few comments which popped up a little later here on the Twitter wall regarding quality, and we will link then into finances. Professor de Bont said regarding oncology and the role of primary healthcare. In the Netherlands, hospitals have taken over primary healthcare cancer care. Primary healthcare does not have the expertise to cover that, and in the hospitals, nurses, specialized nurses, take over the GP role for oncology. So very clearly positioned in hospitals. Martin Sprenger from Graz posted on YouTube, how much has quality in primary care to do with the training of health professionals? That's something which we have addressed in some of the discussions earlier. Maybe we can come back to it later, or you can link it to the next question, which Professor Carby posted earlier. He said, which quality indicators should be incentivized? Structure, process, or outcome? So where would you put the money or the incentives, the financial incentives to nourish a new quality paradigm?
So, well, hello. Well, in case of the pay for performance, so the quality indicators that we found was more in a collaboration with the quality team. So what we looked at is the primary healthcare centers, all in collaboration between different healthcare specialists. So in our case, structure, process, and outcome are all three actually quite important aspects of a pay for performance incentivized payment system. However, in that case, we would just act according to quality team and so incentivize the structure. For example, if they would collaborate with more healthcare specialists, for example, if the GP would consultate with, for example, with the pharmacy before giving a prescription, or the process of having more meetings together, and by having those meetings, you've got a better outcome eventually because you discuss the case of the patient more into detail.
Antoinette, Professor de Bont adds the question, would pay for performance work, for example, for less stable diseases than diabetes? Would it work for frailty? Would it work for COPD? Again, you?
Yeah, I mean, those are chronic diseases, and it's a disease which is ongoing for a longer period. And for my opinion, if it's for a chronic disease, it's even more important to work together, to collaborate with more specialists, and like actually to pay them, like giving them like a bonus for those performances if they collaborate more on a longer term. So I think it does work like for chronic disease and ongoing diseases, and maybe incentivize put more attention to chronic disease, put more attention to COPD, and try to solve it in a more collaborative, more specialist way with different levels.
Okay, thank you. Another question, how long would the negotiations about the new payment methods take in Austria? Are there any shortcuts? Well, here we... Yeah.
Well, yeah. Yeah, we were like thinking about it, about like the payment system, how long it would be, and what we found out is the way of answering the idea of payment system and to implementing a good way of a payment system is to lower the barrier. So yeah, a physician is not that easily willing to change the simplistic way of a payment system to a more sophisticated. So we will not propose like changing the fee-for-service into a big capitation payment. So that's why we focused on like adding this fee-for-service with a small like pay-for-performance aspect to lower the barrier and to make it more accessible on maybe a shorter term for now. But of course it can be more advanced over time, and maybe we can find like different and new ways to solve it.
Okay. Thank you very much. We move to the last presentation. Here is your applause. Thank you. Regarding the shortcuts, maybe the 200 million euros, which are now well close to be decided on, might help to find the one or other shortcut for the one or other pilot projects. There's more questions up there, but I leave it to you. I think it fits well for the final presentation, for the final discussion. Who takes over first? Katrin.
Thank you very much. Good morning, everybody. We're very excited to be here and to present you our toolkit on negotiating finances and understanding risks related to primary healthcare networks. The selected approach for developing our toolkit is based on the combination of stakeholder feedback as well as empirical evidence. Our toolkit is based on 6 pillars, which you can see on this slide now, and it's focused on rural areas, to be more precise on the concept of networks. So to present now the main findings of our paper to this audience, this presentation will elaborate on the financial incentives and risks, as well as on the stakeholder part. Ultimately, the tools that we provide in those 2 sections will help the GP to know how to prepare for and enter into presentations. So let's get started with the financial section. First of all, in order to understand how physicians are paid and how remuneration in the healthcare system works, it is essential to be aware of different existing payment methods. Therefore, we provide you with a table now, but be aware this is just an excerpt with the first 5 most relevant payment methods. You can see here the characteristics of each payment method, the positive and negative impacts, the system implications, as well as potential areas for application related to primary care functions. But out of those 5 most relevant payment methods now, what is the most ideal one, or what is the preferred one? So literature reveals there is no clear consensus on that. But in Austria, there is a clear vision. Austria wants to design payment methods in a flat rate, performance-oriented, and transparent form. Therefore, in order to ensure like the changes are also accepted, the payment method changes are accepted, consider keeping the current combination of fee-for-service and bundled payments, but adjust it slightly to regional differences and to the new scope of activities that is attached to the primary healthcare networks. Besides, it's also discussed in Austria to link certain performance indicators to the payment. So in our paper, we also included a table on different quality indicators, which is especially useful for rural areas, which shows which indicators could be linked to bonus payments. A further tool that we want to provide now in this financial section relates to risk management. A GP should be aware of the risks that could occur when he runs a practice, as those might also have financial implications. So therefore, we developed a tool that kind of tells you how to develop a risk management plan. And one essential part of that is the risk analysis. So this is the very first step that you can see in this presentation on this 5-step approach. Afterwards, you should also identify measures and also select on those measures to reduce the risk, which is often referred to the concept of risk controlling. And afterwards, you actually implement the measure and also monitor it. So on the next slide, you can see a template that helps the GP to do a proper risk analysis. So for example, you evaluate the probability of a risk occurring and also the severity, the impact of that risk occurring might have on your project. and thereby you can calculate a risk factor. So now, after having identified and assessed all the risks, it's also important part of risk management, how to control those risks now. You can see on those slides now that there are 5 most important techniques. Unfortunately, I can't go into detail with those methods, but I would be happy to answer all your questions afterwards, so just make use of the Twitter function. However, I would like to highlight there's one specific financial tool that is often used to reduce the extent of a potential loss, and this is risk adjustment. Risk adjustment is especially useful in rural areas, as you know that the population profile in rural areas is differing from the one in urban areas. So what's to keep in mind now in this section? First of all, it's important to have a clear understanding of the prerequisites for, as well as the boundaries of application for different payment methods. Second, also try to detect the risks and know how to control them, and this can be done by using a risk analysis. And the third thing, which is important, is know your population, know your patients and the demographic profile. So let's continue now with the stakeholder session. Knowing all actors involved in negotiations and also their potential interests, impact, or roles is essential. So a further tool is a risk analysis that actually helps you to identify their stakeholders, their roles, and their potential contributions, both positive and negative. And afterwards, you're also able to prioritize on those stakeholders based on their level of impact. In our paper, we also did a proper stakeholder review for the situation related to establishment of primary healthcare networks. And within this review, we also thought about different concerns of each stakeholders and how those concerns might be overcome. However, in this presentation, we want to focus on a further tool that is very practical, which is the impact interest matrix. On this tool, you can also rate the interest level and the impact level, which helps you again to prioritize on your stakeholders. So what to keep in mind from that section? It's important that you know that stakeholder analysis might be a time-consuming tool, but it is very helpful and highly valuable. Second, try to get an overview of the political landscape and also what this effect might have on your situation. Third, due to the fragmented structure in Austria, the attitudes towards the realization of projects might differ among institutions on a federal level. And lastly, don't forget that a stakeholder analysis also helps to reveal different networks of interaction among stakeholders.
Right. We have now presented you with tools on both, or from both a financial and a stakeholder aspect. And in the negotiation part, we wanted to show how these tools could be linked together. We wanted our approach to be very practical, and we therefore drew our inspiration from a manual created by the American Medical Association. And we identified these five key areas. Now, I'm not going to go into details about this because you find that in our paper. I just want to mention a few things to give you a little taste of what our paper contains. For example, in part 1, evaluate your position before negotiations. That's giving yourself a value. Now, in that part, stakeholder analysis along with impact and interest matrix will be very useful. There's determining your negotiation team. There's determining your negotiation goal, both small and big. And there is gathering data. On gathering data, I just want to mention, as my colleague said, the importance of physicians knowing the patients of their catchment area. Now, this data will gain additional value once it is actually combined with the tools presented in the financial and the stakeholder part. Lastly, there is the negotiation part, and here I just want to mention that it is very important to know the legal framework when entering into negotiations, and we therefore provide a tool which gives an overview of the current legal situation. Now, we know that there are more tools needed when entering into negotiations, and we therefore provide a table made by the World Finance Corporation, which allows you to make a stakeholder engagement analysis, which then in turn will allow you to prioritize your stakeholders. Who are you going to approach first and why? We also give some suggestions of as what to do if you encounter reluctant stakeholders. Additionally, we provide information on seeing GPs as social entrepreneurs. And as my colleague mentioned, it's important to understand the political landscape, and we therefore also provide a tool on public relations. Should there be a need for further information or education on negotiations, we provide links to lectures by the Emory School of Law. Now, as a final remark, as you've seen from our presentation, the complexity of this field is not to be undermined, and we highlight the importance of being familiar with both the financial and the stakeholder aspect in order to enter into negotiations successfully. And we would like to extend our sincere gratitude to all the stakeholders who so generously contributed to our paper, and we thank you all very much for your time.
Thank you very much, Ingeborg and Katrin. Let's move again to our Twitter wall and see what we have here. What is the relation between risk management and financial management in primary healthcare, asks Professor de Bont. Yeah.
I think, first of all, it's really linked to each other. First, in terms of risk, when a loss occurs because of a risk, that most of the time or often that will end up in a financial or a negative financial result for the GP and his practice. So in that way, it's really related to each other. And I think also for the negotiating of it, especially in rural areas, it is important to be aware of your risks related to your environment to actually negotiate, for example, for a payment system, for a certain payment system.
And Antoinette de Bont asks further and says, which stakeholders would be impressed by a risk analysis? So how can you perform a risk analysis in cooperation with selected stakeholders in a way that they see the advantages of this kind of analysis?
I think in the first place we introduced a whole stakeholder analysis for the GP itself to know its position into negotiations, and it's important for the GP to actually know what the different tasks and roles of the stakeholders involved are. And so I would say that it's most of all important for the GP itself, but also, for example, with forming alliances with other GPs. When they form an alliance, they will be stronger in negotiations with other stakeholders. So they might convince other GPs, helping them out or support them by doing a stakeholder analysis. So yeah.
So it would be impressive if a GP or a primary healthcare center would show its limitations and communicates its limitations and not claim that they can cover and do and solve everything. I fully agree. If I look up here, there's another very provocative statement from Otvar Karbe. He quotes the editor-in-chief from Health Affairs, Robinson, by saying, "The three worst ways of paying GPs is salary, fee for service, and capitation." I asked in my reply to him, or via Twitter, I asked him, okay, what's the alternative? And there's a kind of an answer. No perfect way of paying GPs. The main barriers to reaching goals should determine payment method. So what are the barriers you observe?
Well, we talked with a lot of different stakeholders and we tried to really listen out what are their barriers that they have to how to change to a primary care function. And I think there is a catalog of measures that could be done. Like, first of all, it's always important to not only see the valorization of the GP as a profession, but also the valorization of other health professionals, because it is in the end the team that is working together. So we should address that point for sure. Another barriers, in Austria especially, we have to be aware of the fragmented structure. So we can't say we have a universal system where the stakeholders react in the same way. So we have that fragmented structures, and therefore it's very important to try to grasp the attitudes of those federal institutions, because they might be different. If I'm allowed to bring an example, for example, in Upper Austria, where they're working on the primary healthcare center in Enns, we can assume that there is a strong support from both the sickness fund as well as the Land of Upper Austria with respect to that, but that might differ, of course, and that's also kind of a challenge to get to know what is the different attitude of those institutions and how can we position ourselves in the respective federal state.
One final question, Ingeborg. Having studied the stakeholder landscape of the Austrian healthcare system with regards to primary healthcare, what would you recommend a young health professional who wants to enter the field? In which of the states of Austria would you start your primary healthcare center or network, or where would you feel most supported?
Firstly, as a Norwegian, I'm not sure I should answer this. I don't want to become unpopular in the country that has treated me so well. However, I think, as Katrin mentioned, Upper Austria has shown some great potential and a lot of willingness to make this work. I'm not going to point out any bad guys, but there are certain Bundesländer that oppose it perhaps a little more. And therefore also our toolkit is made in a way that you can sort of tailor it to where you are and where you as a young GP wish to set up a practice.
Thank you very much for this diplomatic approach. We don't teach health diplomacy, but I can see that you approach this in a very diplomatic manner. Thank you very much for this. Here is your applause. Thank you. So we are moving towards the end of this live stream, and there's very little to add. You have now followed 6 different presentations. One of the final tweets was about capacity building, and the question that Otto Harvey presented to us was: is our financial incentives the solution for capacity building? Well, I think these 200 million euro carrot, which is out there, might at least provide some means to launch some pilots. Irina Romberg posted on Twitter and said, well, are there any criteria how these 200 million euros will be used? And we actually don't know. The current government bill, the result of the 15a-Vereinbarung, doesn't tell us anything about criteria. But if you talk to policymakers, and I heard a lot about their current views by discussing with you, we realize that they have very strong opinions how to spend their money, how to install primary healthcare in different regions. For example, in one region, there is a very concrete plan to link the new primary healthcare networks and centers to existing voluntary organized mobile care units, and it seems that behind the scene there is a clear idea how to use the money in the next 5 years, but there's obviously also some space to develop further ideas. Thank you very much to all our students. Thank you very much for the audience. I saw that between 45 and 55 people were following us online. We will also produce a recorded version of this session and we'll send it to all those people who were not available this morning. And for all of those who are interested to work more closely with our students and future graduates in this or other topics, I would like to remind you about the programs which are connected to this course here. It's one group in this room is studying Health Economics and Management in the European Master in Health Economics and Management, jointly offered by the University of Bologna, Management Center Innsbruck, Erasmus Rotterdam, and the University of Oslo. Here is the link. And a second group in this room is studying International Health and Social Management here at the Management Center Innsbruck. Here is the link for further information. So at this point, I have to say thank you very much to all of you. Please contact us